right, great. Well, thank you. So I'll start just with that. And I think want to recognize that what we're talking about is the non-immunologic therapies. So I kind of feel like the same sort of backhanded slight that the non-colorectal cancers get in GI ASCO, right? They'll say, got colon cancer over there, and then over there is the non-colorectal cancer, right? So this is the exact same thing. We have immunology over here, and now I'm going to talk about non-immunology. So kind of the everything else category. So the points I want to make, and I think just make the point that everything we'll be talking about here is not approved and still experimental for these tumor types. So I wanted to touch on three different areas. One is kind of chasing the rare subsets, talk about these fusions that we got the question on. I'll talk about drugging the undruggable, how do we go after some of these holy grails, and then just a few agents, or two agents to keep an eye on that I think actually represent two different philosophies of kind of novel approaches moving forward. So obviously not covering all the different novel approaches coming out, and apologies if I left off your favorite novel therapy coming forward. So when we are talking about targeted therapies, we're always thinking about what is the target, what's the aberration, and how do we treat it. And I think this is some of the data from colorectal cancer, although you can put up almost any GI cancer here. But what you can see is that there is a subset of mutations that occur commonly, but there's a huge tail. And this tail of mutations and alterations just extends pretty tremendously. So there are about 15,000 different genes that have at least 1% prevalence of a mutation or alteration in colorectal cancer, which means that there is still a lot of subgroups out there that we may be able to stumble across. But when we're talking about this one group, when we talk about these fusions, I'll show you some kind of provocative and interesting data, but we have to start off by just acknowledging that we are way down in the tail. We're down in these rare subsets of GI malignancies. Most of this data has been in colorectal cancer, although there's some anecdotes in other GI malignancies. So first of all, what do we mean when we talk about fusions? We're used to amplifications, mutations. Fusions, of course, are when there's a DNA break, two DNA breaks, where there is a kind of a flip of the chromosome, and then they're rejoined. And what you end up with is a fused protein. And how these fused proteins change the biology is very disparate. I mean, we're used to the BCR-ABL, for example. Sometimes it's having the kinase domain where you've lost the regulatory domain, or it's a protein that's highly expressed and driven that may have then be linked up to some other oncogene. And so there are a variety of different fusions that have been reported, and they all are very similar. So here's your first the question that we were talking about, but here's an example of one of these. And ALK fusions, even though we think about them in lung cancer, and are indeed seen in GI malignancies at a rare, very low rate, somewhere in the 1 to maybe 2%, if you're generous, rate. And this is a CAD ALK fusion. You can see how the ALK strand is flipped and then reformed. But this is some case reports here of where there's entrectinib that can be used to, and you can see the response there that's present. Now, there's a few other fusions that we can see similar things. The other one that I think there's been some enthusiasm about is NTRK. This is another kinase that is fused and activated. And this is one that we initially thought it was 2%, and then we started looking, and we thought maybe it was 1%, and then we kept looking, and it drifted down to 0.5%. So I think the latest estimate is somewhere around 0.2% of colorectal cancers at least, and I think similar in other GI malignancies. So pretty rare. And so this is a huge hurdle in drug development. How in the world do you develop a strategy and get a drug like this to market? So these are some of the first ones that are being discussed with the FDA that are kind of pan-tumor type. So the proposal being that they are seeing this activity across multiple different tumor types, and perhaps it doesn't matter. This is one where it truly may not matter in what context the fusion occurs, but it's so rare, but there indeed is some activity where this could be considered. So I think that's about the only way that this is probably going to get sufficient data to get to market. But there are a number of studies looking for these patients. Now, the reality is that just because it's a fusion and we target it, and this is actually a fusion that's also targeted by entrectinib, is that you can get these acquired mutations. So these fusions are still able to be, or still have mechanisms of resistance that are similar to what we see otherwise. So this is a report of acquired, two different acquired mutations in this patient. Now, the one that is perhaps a bit of an exception to this is the R-spondin. And it's the exception in that the prevalence of this is actually, not 1%, but in the several percent range. Now, R-spondins, if you look on the top right, are part of the Wnt signaling. And when you have these fusions, this works by actually overexpressing the R-spondin 2 or 3 protein. And so you can see on the left, if you're aficionado of Western blots, that there's a substantially higher expression level of the target. And so this is something that's now can be screened by fusion assays, but also a lot of assays are now just looking at the gene expression level, right? Is the R-spondin level through the roof? It's 10-fold higher than the normal, and this can be a hint of what's going on. Now, we know that this is relevant, as we talked about for other tumor types, because of this idea of mutual exclusivity. And this is something on the bottom, if you can see the R-spondin 2 and 3 fusions are mutually exclusive with APC. And so this is a great sign that's telling us that the tumor only needs one of these two mechanisms to become activated and activate Wnt. So this is one of these mechanisms that occur in the APC wild-type patients. And so if you're hunting for these, keep a thought in the back of your mind. If you send off a mutation panel and your APC is wild-type, that they could be a proportion of those patients, maybe as high as 1 in 6 of the APC wild-type may have one of these R-spo fusions. All right, so when we treat these models, and the clinical data has not been reported, there's some case reports of activity in colon cancer, including some nice responses. But what we're seeing is really this idea of, like any Wnt signaling, we get this differentiation effect. So when we inhibit Wnt, what happens in this setting is that you actually then get a differentiation of the tumor, and you can see in the top, in the H&E on the top left, kind of a standard-looking H&E. Down below it is after you inhibit it with an antibody, R-spo3 inhibitor, that you get a differentiation effect. Now, that doesn't necessarily mean that that these are no longer tumorigenic, but we do see regression and more of a mucinous differentiation. So the tumors don't always regress fully, but when you look at them or biopsy them, they're just kind of full of mucin and differentiated tumor. Now, and this is a key point because, as we'll get back to when we talk a little bit about some stem cell biology later, the anti-Wnt, or in this case R-spo in therapy, may in some models have modest efficacy in the bulk of the tumor, right? That the tumor is still propagating, but it really does reduce that stem cell property. Remembering that Wnt is a key mediator of the stem cell biology in normal epithelium. And so when you do this, you treat and then do the kind of classic stem cell therapy assessment or stem cell assessment, the stem cell properties are diminished. You can't propagate that. There's no reservoir of stem cells as a result. And then even if the residual disease that you then have also tends to be very indolent because it tends to differentiate. And and then can senesce. So I think, this is something that's going to challenge us a little bit on how we are developing the agents. It's not going to be the dramatic shrinkage all the time, but there still can be some meaningful benefits. All right, so off of the fusions. Now let's go all the way to the other end of the curve, right, and talk about what I call the big three for GI malignancies. We talked a bit about Wnt. We'll touch on that. P53 and KRAS. What are some of the potential altered or opportunities that we're seeing there? So first of all, just a reminder that, and reiterate the point we made before, that there's a lot of ways that Wnt can be activated, and one of the downstream results of that tends to be MYC expression, among other things, but that the Wnt pathway is really predominantly APC mediated, but is really prevalent also by many other mechanisms as well. This is colorectal, but can apply other ways. There are a variety of different ways to target it that have been described. We talked a little bit about targeting some of the fusions up at the membrane, but there's a number of agents, including tankerase inhibitors, some protein-protein interruption, ICG-001 and PRI-724 that have kind of been percolating along in early development for a while now, that are now looking at the core binding protein. You'll see at the top that there are a number of agents that really can target high up in the pathway, and we'll touch on a little bit of those. But targetable Wnt, at least, is a smaller subset. And I think really this is defined by those where we don't have the beta-catenin, APC, or more downstream signaling. So here are some of the things that's talked about. R-spo fusions, we mentioned. RNF43 mutation, this is a negative regulator of Wnt beta-catenin, also mutually exclusive with APC mutation and R-spo fusion. And there's inactivating mutations. Again, these numbers vary, but maybe about 1 in 6 as well. And these are seen predominantly in the BRAF mutated sessile serrated adenoma pathway. And there's some therapies looking at that. Now, Notch has been described. This is probably less well, this association with sensitivity is probably less well described. So what are some of the key ones that we're seeing developed in GI malignancies? So LGK974 targets porcupine. So porcupine, besides being a cute named enzyme, is responsible for Wnt ligand secretion. So remember that Wnt can be a paracrine and an autocrine effect. And so the Wnt ligand secreted then binds to the Wnt receptor on the surface. So this is actually reducing the Wnt ligand secretion. And the readout, of course, of all of this is what's happening with the Wnt pathway, right? As you remember from APC mutations and other things result in nuclear beta-catenin, and that's a nice readout. Does beta-catenin get into the nucleus and cause all those gene transcription? So anyway, just some pretty pictures here to show you that there's lots of beta-catenin in the nucleus, but when you give an inhibitor of porcupine, and this is a new one actually, ETC159, that we're starting to see more studies come forward with, you can see these nice blue nuclei, right? There's no staining in the nuclei, and that's an amazing results in such a target that it really has been difficult to drug. Just mention 2 other agents that are in this class. These are agents that are the extracellular Wnt binding domain antibodies. So these are IgG. Immunoglobulin domain. This is a frizzled 8 extracellular domain, and you can see some in models. These decoy receptors have been beneficial in the preclinical models and are being explored clinically. The other is vantictumab, and this is again a frizzled targeted agent that has really been optimized not just to be the decoy receptor for frizzled 8, but now this is a more traditional binding inhibitor to the whole panel of frizzled. So some key tools that we have, and I think we're now seeing trials moving forward. There's been a lot of interest in this in colorectal, but also pancreatic and HCC. And so there's at least grand plans to move these forward. What we're seeing is this is being developed a lot in combination with chemotherapy, with the idea that this targets that stem cell population, right? And that you still need something to handle the bulk of the tumor before looking at the combination. And this is just some preclinical models showing at least some additivity in a syngeneic model with the frizzled and irinotecan combination. All right, so what about RAS? Right, so this has been one of the holy grails of targeting, and certainly we still have the potential and lots of great discussion about ways forward, but it has been a little disappointing. And this was some data that I think gave a little bit of a glimmer of hope. And it's just that, but we'll take that. When we're in the realm of targeting RAS, you'll take any glimmer of hope that you can here. And what we see is this is a Chiron, now Roche inhibitor 5126766, that is a dual BRAF and MEK inhibitor. So it actually has activity against both. And so it does allow a higher dosing and then a higher degree of MAP kinase pathway inhibition. So this gets to the point of, is it just a matter that we just have not been able to dose high enough with our MAP kinase inhibitors to get the activity that we're looking for? And here's just some preclinical data that shows that this is different than a MEK inhibitor. So when you look at the open circle, now using the Chiron labeling, the open circle there just showing it shows regressions in these models, and then in models that were treated with the MEK inhibitor, then you revert and add this drug on instead, you can get some regressions then. So clearly this dual activity is doing something there. Now, of course, here's some of the initial clinical data. And it's a smattering of different tumor types, as you can see here. But as you can see in the far right, there are some RECIST responses. And I think encouragingly, although the numbers are small and we don't yet know how well this is going to be replicated across all the different tumor types, but 6 of the 15 patients treated with a KRAS or NRAS mutation had a response, right? And so that's a 40% response rate in a KRAS mutant setting. So pretty amazing. We'll be seeing more data coming out at AACR and ASCO on this. Where and how this could roll out, or whether this is just some data that may be a little provocative but not quite replicated, we'll have to see. And finally, the other one in the kind of the most common canonical pathways in GI malignancies is MYC overexpression. And there's a BET inhibitor, bromodomain inhibitor, that is really involved in the signal transcription initiation for MYC, as well as other genes. And so this is an epigenetic agent that actually, as you can see nicely in the top right, does a good job of inhibiting MYC. And MYC has been one of those holy grail ones as well. And so I think certainly now you can see some of the preclinical down in the bottom right. Clinical data will be coming at ASCO this year as well. So that's, I think, also an area of interest because of its substantial relevance in GI malignancy. All right, so we've touched on fusions. We've touched on the drugging the undruggable, so just touch on 2 different areas that I think worth keeping an eye on as well. These are 2 different strategies, and I think we'll touch on the implication of this as well. So what about MET? So MET is a receptor that we have been chasing for several years at least. There has been interest in this just with overexpression. but the dependence of MET gene amplification has really been highlighted as perhaps the right population to explore. MET gene amplification is a well-described mechanism of resistance, acquired resistance to EGFR inhibition. And there was a study that's been reported out looking at an EGFR plus cabozantinib MET inhibitor. And this combination study, this is run by John Strickler at Duke. And you can see the 3 different dose levels and moving forward. So this is one of his patients. And just to show you in a patient that had a really nice response to therapy, and it was durable as well. The difficulty here is that MET amplification is not really seen in treatment-naive colon cancer. It's rare unless there's been prior EGFR. And so this is data Commonwealth Rogoff Institution had published this recently. And you can see the prevalence is very low, down in those single digits in EGFR naive patients, but can go up to about 20% in EGFR refractory patients. So you can drive patients to this pathway, but it's not a very critical pathway initially. And this, I think this slide's been shown before, but John Strickler is coordinating an effort through a crew that will be targeting these different mechanisms of EGFR resistance and other more refractory biology of colon cancer. And the hope is that these anti-MET, for example, could be one of the targets that could be explored. Now, these strategies, and I think this is one of many different strategies of how do you go after a acquired resistance to therapies. You know, lung cancer has been very successful, right? Inhibit your EGFR, and then you inhibit the resistance mechanism, and then you inhibit the resistance to the resistance mechanism, and so on. So is this a strategy that may apply in colorectal cancer? And we certainly hope so. But at the same time, we have these kind of warning flags that keep popping up. And one of these is this idea of heterogeneity, that when we're developing resistance to these therapies after EGFR, it's not one mechanism, but multiple. Now, this is so small as to not be legible, but across the top are all the different mechanisms of resistance: EGFR ectodomain, amplifications, KRAS, NRAS being acquired, and then the rows are the patients. And you can see that for each of those rows, there's multiple different mechanisms that can be identified. And when you look here at the MET column, you can see that these MET amplification events are not necessarily mutually exclusive with these other alterations. And that's the hard part, that yes, we may be able to knock off one of the resistance clones, but what about the other resistant clones as well? But this is the biology we're going to have to address. So perhaps what we have to do is look at our alternate strategy. And so this is the idea, well, if we can't, if the diversity of the tumor, the heterogeneity is such, perhaps if we target some of the cancer stem cells, that may be one approach. And so wanted to share some data, slides from Axel, looking at one potential inhibitor that I think there's enthusiasm for in GI. And this is an agent that's targeting STAT3. So what do we know about STAT3? So STAT3 is a key intracellular signaling pathway. It's related to a number of inflammatory responses, but is involved in kind of many of the cancer stem cell properties. And this is an inhibitor, BBI-608, that when one targets these pathways, you can see a substantial inhibition in phospho-STAT3, so it hits target, and then this is phospho-STAT3 again in a patient sample. So what's the preclinical data? So because of its cancer stem cell property, you can look at some of these alternate approaches, such as ability to suppress metastases. So if the metastatic property being seeded from these cancer stem cells may see a greater degree of activity with these inhibitors than you would otherwise. And so just some data, mice data demonstrating livers the kind of the nodular one on the top being tumor involved, and the more smooth, normal appearing liver on the bottom with the treatment. And as we talked about and alluded to before, a combination of these agents that have stem cell properties with chemotherapy can be beneficial here. And here you can see at least additivity of 5-FU and BBI-608 in a CT26 syngeneic model. So Julian Hubbard led a study, the BBI-608 study at Mayo. This is a population that had it was pre-treated in many of the patients that you can see there, and there's a combination with FOLFIRI. Toxicity was reasonable. Grade 3 toxicity was fine. I think encouragingly, bottom line here is that there was a number of patients that had prior exposure to FOLFIRI, so 11 of the patients did, and of those, there were 3 responders, or a 27% response rate, at least prior FOLFIRI exposed patients. And then certainly some signals of activity there. So, so this is something that I think is encouraging, and the next step then is a randomized phase 3, which has finished enrolling. Is that, that's ongoing?
It started.
Started enrolling, okay. Okay, so started enrolling. There's also efforts in gastric cancer. That one's finished enrolling, yeah. Right? The gastric cancer study is finished, and then there's a pancreas gemabraxane study that's going to follow along as well. So this is one that we're going to see a lot of exposure in the GI space, and I think some enthusiasm based on this and other data. Okay, so I'll conclude the novel therapies and just say clear signs of activity in fusions, but again, these assays are not widely available. They are on some paneling, and it's going to be hard to see the path to market for some of these. There's going to be huge efforts to get these agents approved. We're encouraged by some of the successful Wnt targeting in the trials. We're still talking about picking around the edge of Wnt, that we still, those settings where we have mutated APC or beta-catenin, where we can't yet address. I'm always a perpetual optimist, but I do see some glimmers of hope there in targeting MYC. I didn't show you some of the P53 data. It's a little more immature. And then perhaps with the dual inhibitor, maybe there's some signals there in a RAS mutant population. And then I just shared 2 different strategies, each with their own hurdles, targeting acquired resistance mechanisms, for example, MET, and then addressing some of these stem cell characteristics, and that's the example there being STAT3 and BBI-608. So thank you very much.